Hello everyone, my name is Ning Mai. I am a third-year pharmacy student at the University of Kansas School of Pharmacy. Today I will be presenting with my classmate Esther Anderson about a pharmacogenomics topic related to CYP2D6 encoding. It is the implementation of CYP2D6 guided coding prescribing in clinical practice. First, let's identify pharmacogenomics. Pharmacogenomics studies how a person's genetic makeup affects their response to medications. Genetic differences can change how drug is activated, broken down, or transported in the body, and how the body responds to the drug. The goal of pharmacogenomics is to improve drug effectiveness, reduce adverse drug reactions, and support more personalized prescribing. Therefore, pharmacogenomics helps match the right drug and dose to the right patient. Not all patients respond to medications the same way. Some get no benefit while others experience toxicity. Pharmacogenomics helps explain part of that variability. The tools we use are ClinPGX, a resource that curates and disseminates information on how human genetic variation affects medication responses, and CPIC guideline, or Clinical Pharmacogenetics Implementation Consortium. Next, we will identify some definitions used. The first one is prodrug. It is a substance that has minimal or no pharmacological action and has to be converted into a pharmacologically active drug through metabolism. In our study, codeine is the prodrug, and it is converted into morphine, an active metabolite responsible for pain relief. After entering the body, codeine will be metabolized by enzyme CYP2D6 in the liver and converted into morphine, an active metabolite and also an opioid. The morphine will then bind to opioid receptors and produce pain relief as well as opioid adverse effects. Since this conversion will determine if the patient gets pain relief, no benefit, or toxicity, and codeine doesn't work the same in every patient, we need to do gene testing to determine whether codeine is an appropriate and safe choice for the patient. And here are some definitions used in gene testing. Diplotype is the exact pair of alleles or the combination of the two gene copies a person has. Activity score reflects how much CYP2D6 enzyme activity the patient is expected to have. Basically, it tells how well those alleles are expected to work together. And phenotype is the predicted metabolizer status based on the genotype. It is how the gene is expected to function. Now we will dive into why CYP2D6 matters for codeine. Again, codeine is a prodrug that must be converted by CYP2D6 into morphine for pain relief. Low CYP2D6 activity means less morphine formed, leading to less pain relief, and high CYP2D6 activity is more morphine formed faster, leading to more toxicity risk. Below are the CYP2D6 phenotypes. The first one is poor metabolizer or PM, which is too little morphine formed, leading to too little or no pain relief. The next one is intermediate metabolizer or IM, which is reduced morphine formation, therefore weaker response, meaning the patient may feel pain relief but not much. Next is normal metabolizer or NM, which is normal expected response, meaning the patient will feel pain relief with usual standard dosing. The last one is ultra-rapid metabolizer or UM, in which too much morphine formed too quickly, leading to high risk of toxicity and respiratory depression. And here are the CPIC recommendations for each phenotype. In PM, it is recommended to avoid codeine since not much effect is seen. In IM patient, They can use usual dosing, but consider an alternative if response is poor. If patient is a normal metabolizer, they can use usual dosing. We also avoid codeine in UM patients since the risk for toxicity is high. This is the implementation plan for CYP2D6 testing and coding used in hospital care. First, we need to assess patients' clinical concern. For example, poor metabolizers may not get pain relief, or ultra-rapid metabolizers may have serious opioid toxicity. We should check prior CYP2D6 results if applicable. If the patient has never done the gene testing before, we will order CYP2D6 genotyping before starting coding. Sample can be collected by buccal swab or blood. The phenotype results will then be documented in the electronic health record or EHR. And then we will identify if the patient is a candidate for coding. The pharmacist will review indication, pain severity, age or pediatric precautions, current medications for CYP2D6 interactions, and then document recommendations in the EHR. At this point, EHR alert system may file when coding is ordered. For CYP2D6 ultra-rapid metabolizers, the alert can recommend avoid coding and selecting an alternative analgesic. The result is used to guide therapy later on. In the follow-up step, the result is put in EHR as a separated result so it can be reused for future prescribing. We will also add pharmacist or clinical decision support note with recommendation, and then educate patient and caregivers on what the result means. And then pain control will be re-accessed and adverse effects will be monitored after therapy change. The implementation goal is to make sure CYP2D6 results are ordered, interpreted, stored in the EHR, and actually used at the point of prescribing. In ambulatory care, the most important implementation issue is timing. After identifying the right patient for coding, CYP2D6 gene testing will be ordered before prescribing coding if the patient doesn't have one before. Frequently, when coding is considered, collecting sample is the first thing to do during the clinic visit, and buccal collection is often used in ambulatory care because it is non-invasive and convenient. Pharmacists will then review genotype and assign CYP2D6 phenotype. They also check for drug interactions that can change CYP2D6 activity. Results will be returned to the EHR as a discrete result. Pharmacists will use an active clinical decision support. This will alert prescribers when they prescribe coding and an actionable CYP2D6 result exists. After that, pharmacists will send recommendations to the providers based on the pharmacogenomics results. Recommendations should tell prescribers exactly what to do. For follow-up, pharmacists will reassess pain relief, sedation, and other opioid adverse effects to determine the need for alternative analgesic. Recommendations are documented in the ambulatory chart for future visits. Pharmacogenomics results should remain available for future prescribing. Pharmacists will need to educate patients on gene testing as well as what CYP2D6 testing for coding is. Pharmacists can explain to the patient how their body may process coding and how the test helps predict patients' responses to coding. The goal of the test is to help choose the safest and most effective pain medicine for the patient, reduce failure prescribing, and lower the chance of serious side effects or poor pain control. The pharmacist can also explain some benefits of the test to the patient. For example, the test may help avoid a medicine that will not work well. It may help prevent serious side effects from coding, and results may be useful for future medicines affected by CYP2D6 and not just coding. Gene testing also helps guide safer pain treatment in clinical practice. However, limits still exist. Other factors still matter, such as age, liver function, other medication interactions, and overall health. Results may not explain all side effects, and turnaround time and insurance coverage may vary. Therefore, test does not replace clinical judgment. Overall, gene testing helps personalize treatment, but it is only one part of the decision.
TK is a 22-year-old Caucasian female who presents to the pharmacy to pick up her new coding prescription. The history of the present illness is as follows. Today, TK fell off a ladder when helping her neighbor with yard work. She sustained a sprain to her left ankle. She has some bruising, cuts, and abrasions to her arms and legs. She has some back and hip muscle soreness in addition to the pain in her ankle. The ankle pain is what is bothering her the most. TK was seen in urgent care and it was determined her ankle does not have a fracture. The prescriber wrote a prescription for her for Tylenol with codeine, 300 milligrams of Tylenol per 30 milligrams of codeine, 1 to 2 tablets by mouth once every 4 to 6 hours as needed for pain. TK's past medical history includes a tibial fracture 3 years ago after a skiing accident and is otherwise unremarkable. Current medications include gas birth control, loratadine 10 milligrams by mouth once daily for seasonal allergies, and a daily multivitamin. Despite the opioid crisis headlines, Tylenol 3 remains relevant for 3 reasons. Number 1, synergy. The combination uses 2 different pathways. Acetaminophen works on the central nervous system while codeine hits opioid receptors, allowing for effective pain relief with less of each drug. The cost. Generic versions are extremely inexpensive, often less than $1 per day for treatment. And third, safety profile. Compared to NSAIDs like ibuprofen, Tylenol 3 does not cause gastric bleeding or kidney strain, making it a safer choice for the elderly or those with sensitive stomachs, provided that their health is monitored. TK recently obtained pharmacogenomic results from an outside lab. These results are viewable from the electronic health record database accessible by the pharmacist on duty. A major metabolizer of codeine is the hepatic enzyme CYP2D6. TK's CYP2D6 diplotype is *5*6. Per CPIC guidelines, the activity score of this diplotype is 0. Because her activity score is 0, the phenotype shows that she is a poor metabolizer, and TK would actually gain no benefit from taking the codeine. Our recommendation is to use an alternative option for analgesia, such as naproxen, ibuprofen, or acetaminophen, and the pharmacist can inform the provider of these changes. In conclusion, pharmacogenomics is an exciting and relatively new field to help guide medication treatment options. Pharmacogenomics is an example of precision medicine, where we utilize specific, unique patient characteristics to formulate and implement a personalized treatment plan. Pharmacists can participate in pharmacogenomic data interpretation and recommendations, choosing an appropriate lab, providing information about cost, utilizing the electronic health record to post results for other healthcare providers to review, and providing patient education are all important ways pharmacists can assist in pharmacogenomic implementation. Here's the references that we used for our presentation, and we want to sincerely thank you for participating in our presentation. A special thanks goes to our faculty advisor, Dr. Judy Wu of the School of Pharmacy, and additional thanks to Dr. Dennis Grauer and Dr. Jeff Pierce, who provided feedback and suggestions for our presentation.